Hey everyone, I'm Dr. Arthur. I'm one of the pediatricians. I brought with me a patient. Here, come over here, Jonas. Say hi to all the people.
Hi.
Hi, this is Jonas. He is going to be your physical exam model today. And then my wife, Rebecca, will be the mom for them. She's going to work really hard at acting that part. So, Jonas, come on over here. I'm going to just walk through how I do a physical exam, and I'll stop and tell you a few things. And this is completely unscripted, so anything that happens, please excuse. And then we'll just sort of go until he gets bored. So, all right. So typically when I start a visit, so let's pretend that Jonas is a newborn, because that's the exam that you will do a lot in the nursery, and you'll do a lot of these in the clinic as well. So Jonas, I need you to act like a tiny baby. Can you cry like a tiny baby? All right, Jonas is a tiny baby. So when I'm examining a tiny baby, the first thing I try and do is, oh, that's a laughing baby. The first thing I try and do is do as much of the physical exam as I can before I take the child out of their mother's lap, because as soon as they start making noise, it makes it harder for me to do an exam. So I start by listening to the heart, sort of the critical parts. I try and listen to the heart before the child starts crying. So, and I'll talk more about that in a second when we put him on the table. So take a listen to your heartbeat. That's a healthy heartbeat. I do make comments throughout the exam just because otherwise you're just sitting there awkwardly. So you got a healthy heartbeat. All right, then I listen to the tummy. Where's your belly button? That's pretty good for a newborn.
Hi, sir. It's right here.
It's right there. All right, let's listen to that tummy. I do sort of a cursory belly exam. Oh, he's ticklish. And then, if I'm a newborn, that was probably all I can get in the parents' arms. But I was able to listen to them before they started crying, and the heart changing in the first 2 weeks of life is probably the critical thing that you're trying to assess. Okay, so let's have you sit up here on the table, Jonas. Tiny baby Jonas. So, again, pretending that Jonas is a newborn here, and we'll act like he's a bigger kid in a minute. He's going to be lying down, because a newborn, as you have probably already guessed, cannot sit up on their own. All right, let's have you lie down on your back. So, again, I try and put them down on a blanket. I try to have them wrapped. I want them warm. Again, the more agitated they are, the harder they are to examine. So again, most important organ system, I start with the heart. While he's quiet, listening to the heart. He's not very quiet, but he's doing pretty good. So when you're listening to the heart, in the first couple days of life, you are interested in the rate, and you're interested in the rhythm, both which will be hard for you to assess because, well, they're really fast. And then you're interested in heart murmurs, right? All of you will have not had a lot of experience in listening to heart murmurs. What I want you to figure out while you're on cardiology, nursery, and your clinic is the difference between a harsh murmur and a physiologic murmur. You don't necessarily, it would be great if you could identify all of the locations and make a diagnosis based on what you hear, but if you can just stratify, this is a murmur that needs an echocardiogram and this is a murmur I can ignore, that's probably the most important part. So when I'm listening to the heart, I'm listening to see if the murmur has a vibratory sound quality, buzzing, or a harsh sound quality. If it's harsh, it needs an echocardiogram. If it's vibratory and it's quiet, probably under a 2 out of 6, you can probably just keep listening to it. There are some other things you'll learn about in the nursery about where the murmurs are, but we'll talk about it. You can talk about those later. So I listened to the heart. I listened for harsh versus physiologic murmurs or no murmurs. Made sure that the rate wasn't too slow. Things like complete heart block and maternal lupus. That it wasn't too fast. You might get that in sepsis or an SVT. And then I go next to the next probably most important part, which is your tummy. So the tummy actually is probably the scariest part because it's got a lot of organs in it and none of which are going to give you demonstrable problems early on in life. So you think about what lives in the tummy. We've got 2 kidneys. We've got a tickle spot right there in the center. You've got the liver, you've got the intestines, you've got the pancreas. and all sorts of bad things that can live on those things. Probably the most concerning ones would be kidneys, enlarged kidneys, the multicystic dysplastic kidney, neuroblastoma, and for those types of things, they will be asymptomatic at birth, and your ability to diagnose them, or hydronephrosis, depends entirely on the child's ability to have a soft tummy when you examine them. So that's why I do that exam right after the heart. They're still quiet, and I try and push as deeply as I can, usually putting my hand under their flank to sort of push the retroperitoneal space towards my hand. And then I can find, if the kidney's not enlarged, I won't be able to feel it. But if it is, I'll feel it sort of like a smooth egg in my hand. You'll be able to assess the spleen. You can palpate a spleen tip in a newborn. It's sort of hard to do, but it wouldn't be abnormal necessarily. And the liver can be down up to 2 centimeters in a newborn. So try and feel that, because being able to identify liver edge is a useful skill. So be a little bit paranoid that you're missing something in the tummy. Try and get a good, quiet, soft exam. Then the last thing I need to do while they're quiet is, I guess I'll leave this diaper on for modesty's sake. But let's pretend he has his diaper off. We'll scooch this down. The last thing is femoral pulses. So it's hard to get the femoral pulses if a child is moving around a lot. So when they're happy and quiet, I try and either check them here, or I'm going to check them down at the foot. So then, now on the newborn exam, I've done the things I needed to do while he was quiet. Certainly I did sort of a head-to-toe just observational look, but I looked at his heart, his tummy. Do you need a truck, little newborn baby? Here you go. And so at this point, I have done the quiet parts. I'm just doing full head-to-toe exam. Now, it so happens after I do the femoral pulse, I'm here in the diaper area already. So I have the diaper open. I would check to make sure both testicles are down. I would, and then you do for a newborn, you can't do this really after a month to two because their tone is too high. But I do the Barlow and Ortolani. So bring the legs in, and then you just open the hips like a book. Whoop, doop, doop, doop. In a newborn, they have low tone, so you should be able to get the hips. You'll put your sort of finger in the hip joint, your thumbs on the knees, and just open and close their hips. If you feel, if they have a dislocated hip or developmental dysplasia of the hip, when you open the hip, when they just have their legs up like this, because their hip is not in joint, you'll actually be dislocated backwards, posteriorly. When you open the leg like this, then that hip will pop back into the joint and you'll feel a clunk. I probably get one of those like once a year or something like that. So they're not super rare, they're not super common. If you feel clicks and pops, lots of kids have them in their hips and their knees. That's just loose connective tissue. Those will go away over time. Click doesn't mean anything. You don't have to work it up. But a clunk, sort of feeling the hip bump in and out of joint, that needs an ultrasound and an ortho referral. In an older child, just so you know, later, once the hips calcify at 6 to 8 weeks, you have to do an x-ray after that if you're still looking for developmental dysplasia of the hip. Okay, so got your hips, got your legs. I typically do patellar reflexes at this point. Check for clonus by putting upward traction on the ankle. I do this on both sides. You can check for a Babinski at this point on the foot. He's wearing cleats. Most newborns don't. All right, so now I've gotten sort of the bottom part of the body. I'm going to go up to the head. Getting the red reflex is an important part of the newborn exam. It's a very hard part of the newborn exam. What you're doing is looking at the back of the retina and making sure you don't have anything obstructing it. When I look in the eye, I'm making sure that there's not a cataract, retinoblastoma, which would probably be more of a toddler diagnosis, that obstructs my ability to see the red retina at the back of the eye. So in a newborn, they've got goop in their eye from the antibiotics that get put in at birth. It's hard to see. So you should do a red reflex exam. It helps to have the child in a dark room, sometimes have them a little bit upright, have them happy, sucking on something, and then you can get a good look at the eyes. If you don't get it, if you get a terrible red reflex exam in the nursery, it's okay. You should be doing it at every well child visit, really forever, but at least through toddlerhood at the highest time when kids get retinoblastomas. So I take a look at the eye. It's sort of hard. Then I put on a glove, and I need to check the palate, or the hard palate for a cleft palate. and I need to check the nose for patency. So typically I just use my finger. This will just be a little bit weird for him. So let's just pretend I have a finger in his mouth. I'm checking the top of his hard palate, making sure that there's not a cleft there, making sure he can suck well, because again, he's a newborn at this moment. And then while he's sucking on my finger, I include each nostril individually to make sure that both are patent, that he doesn't have choanal atresia or something called piriform aperture stenosis, where you have narrowing of the nasal passages without them being actually occluded. Sometimes kids just get their noses smashed when they're like on their way out, and they will seem to have occluded noses, but over a few days they'll sort of fix themselves. So I've done that stuff. I take a look in the ears with the otoscope. We'll talk a little bit about that later, because typically you're doing it more on bigger kids. I at least try and look at the ears. The canals are so tiny you often see just about nothing. All right, good. So now I've done the entire exam that I could do while he was lying down. So the next thing I do, now this, again, if he was a newborn, this would be a lot easier. I want to check his muscle tone. All right, so first thing I do is I pick him up like this. Ooh, you're a heavy newborn. Make sure that he can suspend his own weight by his arms. If his arms were to go like this, up like this when I was holding him, that would suggest to me that he has a low tone. Then I drape him over my hand like this. Again, ooh, heavy newborn. If he has good tone, he should be able to stretch his legs out behind him. Can you kick your legs out? There you go, like that. A low-tone newborn will just drape over your hand like a wet rag. While I'm assessing the tone that way, I take a look at the gluteal cleft, make sure he doesn't have like a hair tuft or a pit, a sacral dimple, that's what I was thinking about, that would suggest spinal dysraphism like spina bifida. And then while I'm looking at him and he's draped over my hand, I take a look at the spine, make sure that there's no scoliosis or curvature. Then I put him back down. The last piece I do of the whole exam is the Moro reflex. Why? Because the Moro reflex is like simulating to a child that they're falling and then they're going to cry, and that's not helpful to the rest of your exam. So I get him to grasp my hands. That is another neonatal reflex. So he grasps my hands. I draw him up just so his shoulder blades leave the table. No higher. You don't get the head off the table. You're not like dropping this child from the ceiling. You just get the shoulder blades to leave the table, and you let go. And if he's a newborn, his arms will flex, his knees will flex. That's a protective mechanism that goes away by 3 or 4 months of life. That's the Moro reflex. It should be pretty gentle, but he still might yell at you. Then you do a great job swaddling them, make them stop crying, him or her, and then hand the child back to their parent. An important rule is don't hand a crying child back to their parent, because then they think that you're mean. So that's sort of the last part of the exam. Any questions about the neonatal exam? Oh, good. Let me think if there's any other highlights about that.
1, 2, 14.
The other thing you're doing a skin exam. Oh yeah, 2 other things that can come up in the neonatal exam are skin things. So it's pretty traumatic being born. You'll often see bumps and bruises. You will also see birthmarks. It's important to document both, particularly the bruising, because that will change over time. But the birthmarks are important to document as well. And then one thing that you will often see is swelling on the scalp. That could be either swelling in the subcutaneous tissue, that would be a caput or caput succedaneum. It could be a cephalohematoma, which is blood collection in the periosteum of the skull. You could see a subgaleal, which would be a blood collection between the skin layers. That's definitely the worst. It's going to be much more foggy. Whereas a caput is going to be just edema that will be gone by the next day. Make that assessment. You'll talk more in the nursery about how to differentiate them and how to manage those things. Great. Well, you just got 2 years older. So now you can go sit in your mom's lap again. So here's Jonas. He's a almost 3-year-old. And basically my exam, he can run around for a minute. Basically my exam of a 2 to almost 3-year-old is going to be a lot the same. I will still start with the heart. I'll still go to the tummy next. The only difference is that I will try to do even more of the exam in the mom's lap, because a 2-year-old can move, as you can see, and as soon as you put them on the table, you sometimes lose the control of them for the remainder of the encounter. So what I do is I tell the child, I say, where do you want to sit? Do you want to sit on the table, or do you want to sit on mommy's lap?
Sit on here.
You want to sit on that chair?
Yeah.
Okay, I guess you can, as long as they can see you in the camera.
Let's try it.
They can sort of see you. You're sort of down there at the bottom.
Let's sit a little higher. You can put your feet on there.
Oh yeah, that's a good idea. So creativity is also important. So at this point, I'm going to try and do most of my exam in mom's lap. And so I won't talk through the things I've already done. I would do a heart exam. I would again do a cursory belly exam. Do knee reflexes. I also typically will do ankle reflexes in this age group. Look in the eyes, see the red reflex. I use the otoscope to look in the nose. In this age group, let's see your nose. Ew, look at those boogies. He does actually have boogies. And then I take a look at the mouth. Open big. Oh, that's some sort of weird food that you're eating. And when I'm looking in the throat, and I say ah, I'm assessing are the tonsils big, are their dental caries, is there thrush maybe in a younger kid, that would be uncommon above age 1. And then I take a look in the ears. So ears can be a particularly challenging piece of the exam. So again, here's the order. Did sort of neck to feet, then I do the whole HEENT exam, eyes, nose, throat, and then ears. So some children go crazy when you look in their ears. Some children let you look in their ears. Can you go crazy? Go like this. Ah! Good, all right, so he's going crazy. So I say, oh man, this is gonna be a really difficult ear exam, but I've gotta look. Ear infections are probably the most common in this age group, and sometimes I find either ear infections or like weird pieces of gum and paper and stuff in kids' ears when I look. So, if I've got a pretty wiggly kid, I have the child sit sideways on mom's lap. I say, can you put one hand over one arm, one hand on the side of his head, and just give him a big hug.
Hey.
So that's what I typically do. Once in a while, the mom will actually have to get his legs between her two legs to like really hold him down, but typically this is all I need to do. So, give him a big hug, mama.
Hey, hug.
All right, and then take a look. And actually, he's a little bit squirmy, so there you go. What a beautiful ear. So I tell him about all the gumdrops and elephants that I see in his ear, and then I look on the other side. Here, turn the other side. Some kids are like tickly inside of their ear, which is weird. All right, that ear looks fantastic. And so then at that point, I have done pretty much everything I can do with him sitting up. And so at this point in the physical exam, I probably would move him back to the table. I would, again, do a better belly exam because, as I mentioned to you, I get a little bit paranoid about the tummy. I would do the GU exam on the table as well. But what if the child has a tantrum when you put him on the table? There is an alternate way to do the exam. It's probably not quite as good for the belly exam, but it works. So what I do is I say, Mom, have him lie on your lap with his back on your lap and his legs on my lap. So yeah, I think you can think through that. All right, good. So then I have him lie like this, and I say, Mom, you get the arms if he's like really going crazy. And so then I do the belly exam like this. I do his GU exam just like this. Check the knees, check the ankles. I want femoral pulses on this child as well. Again, you're looking for aortic coarct. For some reason, they're not perfusing their lower extremities, so I can do that in this position as well. And so really, I can do the whole exam from here. Maybe not quite as good, but pretty good. Then, if you're taking care of kids in Donnie Pediatric Center or many other primary care places, at this age group, 0 to 6, you'll put a little bit of fluoride on their teeth. I'm not going to use any fluoride on him because apparently he recently got his fluoride. So I will use this tongue depressor to pretend I'm putting on fluoride. So let me show you 2 ways that you could put fluoride on. Fluoride decreases the risk of dental caries. We put it on every 6 months up until age 6, unless their dentist is doing it, which in his case is the case. So here's how I do it. Not everyone does it the same way. Well, first things first, put on gloves. Pretend I have on gloves because the fluoride's really sticky. And if you get it on your fingers, it will stick to your fingers just like it sticks to his teeth. So really compliant kids, one, they shouldn't be eating while you do this, but what are you going to do? Really compliant kids can just sit up while you put it on. Let's pretend he's a kid actually who won't open his mouth. One of the techniques you use for that is I run the tongue depressor along the side of his mouth. Now this is a tongue depressor. Along the side of his mouth. Get it sort of right next to his molars, twist it sideways, and then I'm able to sort of just like torque his mouth open. Once you get that tongue depressor to the back of their mouth, they just sort of gag and open their mouth, and you're like, oh, your tonsils look great. Again, so if he's like really compliant, I put on some gloves. I'm wearing gloves now. Use this gauze to just dry off his teeth so the fluoride is more sticky. And so I'll just sort of dry off the teeth and then paint it on with, now this is a fluoride applicator brush, and then I just paint it on here. Usually it takes like 4 little dips into my little fluoride cup, and I put it along the top, along the back, and along the sides. And then all done. I try and dry the teeth as much as I can before doing this. Some kids aren't going to let you do that, so then just don't do it. Some people don't dry them at all. Now, let's pretend he's having a tantrum. All right, so then remember how I examined him with his back in mom's lap, his legs in my lap. Then I tell him, I say, let's do the reverse. Lie him down with his back, his legs in your lap, his head in my lap. And then I tell mom, you get the hands, I get the head. And then he's like this, just like at the dentist's office. And I clean off his teeth, and then I brush on some fluoride on the bottom teeth, get a little more fluoride, brush it on the I guess my top teeth, his bottom, and then do the same on the backs of the teeth. Really trying to get the molars as much as I can. And then I say, great, you did such a good job, and then he sits back up. Very good. So I think that's the only thing. Really, the ear exam and the fluoride are the things that are different in the older kid exam than a younger kid. Putting on the fluoride is my opportunity to look in his mouth, so if he doesn't open his mouth very well when I'm doing that, my HEENT exam, I just wait until I'm putting on the fluoride. So other things. Yes, in a bigger kid, I didn't do this with him. Doing various eye exams are also useful. This is a little harder for you to see when I show it, but I do check their extraocular movements. I'm just assessing that while I watch. Looking at their accommodation. Sorry, that's his cleats. It's sort of loud. And something called the cover-uncover test, which is covering one eye and having them look at you, covering the other eye, having them look at you, and seeing if he's looking at you with this eye or this eye, if one of the eyes move when they're both supposed to be both straight ahead. That would suggest malalignment or strabismus. Also, if you look at a light reflection in the eye, like reflection from the ceiling or from your light, and you see that it's not centered on both eyes, but he's looking at it, that would suggest strabismus as well. So then as they get older now, Jonas is an adolescent. I will let him just run around the room for this brief description. The difference in adolescence, you need to talk. So basically, as long as a child is going through puberty, basically until they're probably somewhere between 11 and 15, and they're done their pubertal development and growth spurt, I tanner stage them at every visit, meaning everybody gets a GU exam. You can talk to your attending about what they think is appropriate for you to do. Once they get beyond puberty, different people are going to be different about the GU exam on somebody for a girl who's having regular periods, whether or not they're doing a GU exam every time. Again, talk to your attending. For boys, in my view, I think you do a GU exam every time because they're still at risk of things like hernia and testicular cancer and so forth. Again, that's something that can be different between different providers. I guess one other thing to mention is the idea of a chaperone. So in my view, during the physical exam, there should always be another person in the room with you and the child. It's fine to me, it's fine if that's the parent. If for some reason the parent wants to step out, and often parents of adolescents don't want to see me do a GU exam, and they do want to step out, in that case you should ask a nurse or some other person to be there in the room. It just prevents you from liability, and it's probably a good practice for child comfort as well. I think that's all I can think about for the physical exam. Hey Jonas, give me a high five. Oh yeah! You missed? Okay, that's good. So building rapport, that's the other important piece. I tend to build rapport by leading off, walking into the room for a well child, giving them a reach out and read book and reading it to the kid, at least for 30 seconds. You will have a much more successful physical exam experience if the kid likes you. So invest that time at the beginning of the visit to save yourself time on physical exam later, either because your exam goes quicker, or you don't have to go back to your attending and say, I couldn't examine anything because he screamed the whole time or she screamed the whole time. that's all I can think of for now. If I think of anything else, I'll tag it on the end of this video. Thank you for your attention.